Hello, everyone. My name is Mansi Sunu, and I'm head of the marketing and outreach team of Eureka.
My name is Devina Mukherjee, and I am a member of the marketing and outreach team of Eureka. And sir, would you please introduce yourself as well?
My name is Mazda Turel, and I am a neurosurgeon working at the Wockhardt group of hospitals in Mumbai Central.
Okay, thank you, sir. So, Eureka is a student-run newsletter of our School of Science, and we focus on various themes every month. So, it is our volume 5, issue 6, and this month's theme is neuroscience. So, we're very excited to have you on here. And to begin the interview, I'd like to ask you the first question. So, what really motivated you to specialize in neurosurgery, and what were some of the most challenging moments during your training?
So, my dad is also a neurosurgeon, and as a child, I was raised listening to stories around neurosurgery. And every evening, when my dad came home, he used to review his surgical tapes, and I used to sit with him and watch videos of surgeries being played. Luckily, we didn't have Netflix at that time. So I spent a lot of time watching operations as my pastime, and I was really enamored by it. And I thought that it might be a good career to pursue, to be able to really do something with your hands. It's very artistic, creative, and at the same time, the byproduct is that it can help somebody. So that's how I decided to do neurosurgery. And then when I went to medical school, I really enjoyed neurology as a subject. And to combine surgery and neurology, I think is a great art. And that's how I eventually finally went and decided that neurosurgery is going to be my thing. But pretty early on in my career, or in my by the eighth standard, I was pretty sure that this is what I wanted to do. Neurosurgical training, I think, is very complex. It's hard. You have to sacrifice a lot of family time. You have to eat at unearthly hours. You barely get to sleep for a couple of hours every few days. At least it was so during our time. Now it has gotten a little better. And that is the biggest challenge, to be able to you have about 40-50 patients under you on a given day. Every day you have to admit at least 7 to 8 patients and discharge 7 to 8 patients. So from a time uh, consumption point of view, it's very fatiguing, but you get to see such fascinating cases. Every day is different. You get to see things that are that you've never seen before, and that's what makes the challenge of the training worthwhile. Particularly, I think when we are not able to meet the expectations of uh, our seniors, the discipline that they demand, the vigor that they demand, that's sometimes becomes a bit of a challenge. It's also an emotional journey, because wherever you train, you're most often away from your immediate family, and your neurosurgical team becomes your family, and then you have them for your support and guidance. So it's a very vigorous, very rigorous, but a very educating experience training in neurosurgery, which is about 6 years. And that's just when you start learning the basics of neurosurgery.
I think it's great that you developed a passion for neuroscience at a young age. Also, thank you for sharing your journey with us. Moving on to the next question. You've trained and worked in multiple countries, including China, Canada, and the US. How have these international experiences influenced your approach to neurosurgery?
So more than the technical know-hows of how to do stuff, it's the systems and processes which different countries follow is what's interesting to bring back to us. The US has a slightly different system from Canada, which has a different system from China, and in their setup, each of these systems work well. So while you learn many different ways of doing the same procedure in different places, and their approach to pathologies differ slightly, the actual surgical part more or less is comparable to how we do things in India. But sometimes how they talk to patients, how they interact with patients, what the workflow is for patients to get admitted and discharged, those slightly differ in different parts of the world. Their healthcare systems are different, whereas China has a very protocol based healthcare system, and if you have a problem you go to this one particular place only. Canada has a more socialist healthcare system where if you don't have a real emergency you have to wait for really long. The US has very uh, a very wasteful healthcare system, unfortunately. There's a lot of wastage of raw material, of the things that we use, because a lot of it is easily available to them and insurance pays for all of it. So in my opinion, it's best to take the good points from each of these three countries and then try and incorporate it in our practice to the best of our ability. So systems and processes is what you learn from them. How different people talk to different patients, you learn from them. How to use technology to your advantage is what you learn from them. And of course, some nuances in surgical procedures and how to have a reasonable work-life balance is also what America teaches you. So that's what I took back from these three places, and I'm trying to utilize it in my day-to-day practice.
That was very informative. Also, it's interesting to know how practices and techniques vary over countries.
Yeah, they do. Just tell me if you find my answers very boring, okay?
No, they're very interesting. Don't worry about that. Um, so moving on to the next question. What are the most common brain and spine injuries you treat? And is surgery the only option for treatment, or do other modalities exist?
So brain and spine injuries per se, or you mean to say pathologies? uh, Injuries is one part. So, and pathologies is a whole different part that are not related to injuries. Injuries of the brain include head injuries primarily, which happen because of road traffic accidents. India is the road traffic accident capital of the world, where you have one person dying every single minute from a head injury. And similarly, you see spinal cord injuries related to road traffic accidents, related to falls. Patients can become quadriplegic or paraplegic. We've had several people who've come to our hospital working on this coastal road project who've had falls and come to us. So those are the spectrum of injuries. You see a lot of, not a lot, but a reasonable amount of domestic violence. You see wives shooting knives at their husband, hitting their skulls. But those are rare things. Don't get ideas in case you're married. But those are rare things. Um, and those are injuries. So all kinds of injuries: road traffic accidents, falls, assault, violence. We also get a lot of people who've had gunshot injuries. Luckily, it doesn't happen in our part of the world, but international patients delayed, and the bullet is stuck in the spinal cord. They want to remove it at a later date for whatever reason, etc. So those are the injuries. But from a pathology point of view, uh, The commonest problems we see from the brain is brain tumors. That's what my area of expertise and interest is. And then we also see vascular malformations of the brain, like aneurysms or arteriovenous malformations. And we see a lot of epilepsy problems where patients who have seizures may require surgery for correction of seizures. Then there's another entity called hydrocephalus, where fluid builds up in the brain and you may need surgery for that. And there are other conditions of craniofacial pain syndromes, such as trigeminal neuralgia or glossopharyngeal neuralgia, where patients have sharp shooting pain in the teeth and the jaw. Most often they end up going to a dentist, and dentist realizes this is not a tooth problem and then sends them to us, where a nerve is being compressed by an artery in the brain. So that is the spectrum of brain pathologies that we deal with. Primarily in adults. In pediatrics, it's a whole different ball game. And the spine pathologies that we deal with in adults is neck pain, back pain, uh, stuff like tingling and numbness in the hands and legs. What we also call as a slip disc or a herniated disc, spinal trauma, spinal fractures, either because of a fall or because of osteoporosis, tumors inside the spine, infections of the spine. So that's the spectrum of spinal conditions that are treated by us. And the good news is that, like you asked, 80 to 90% of spinal problems can be managed without surgery. Most often, spine issues are corrected by physiotherapy, muscle strengthening, and other modalities of treatment, sometimes such as acupressure, acupuncture. Very few people really need a spine operation. Once all of these treatment modalities have not fulfilled what they need to do, primarily if the focus is pain, then we suggest surgery. Of course, things like spinal tumors or spinal fractures, etc., will need surgery upfront, but a lot of degenerative spine problems, a lot of aches and pains where there is no significant neurological deficit or dysfunction, those can be managed without surgery. Brain problems can be managed without surgery sometimes if you have an incidental brain tumor. Let's say you had a fall and you get a scan done and you see a small tumor that's benign, is not cancerous, that can be observed without surgery. Some other incidentally found things in the brain like cysts, etc., can be managed without surgery. So again, not everything also in the brain requires surgery. It's a case-based discussion that you have to have with the patient and see whether the patient's symptoms match the MRI findings, and then decide whether surgery is required or not. But by and large, most brain tumors cause symptoms and they end up requiring surgery. Then, depending on what the histopathology of the tumor is, you will have to consider radiation or chemotherapy, etc.
Thank you for sharing the common cases and also not very common but rare and interesting cases as well. Also for explaining the difference between injuries and pathologies. That was informative. Now I'd like to ask you about something very common that I'm sure a lot of us wonder. So what exactly are migraines and why is the number of people being affected by it on the rise? And also what are some simple steps by which it can be treated?
So, migraine is a very broad terminology to describe some form of a headache. And those headaches classically affect one side of the head. They're got on by an aura where people sometimes can hear a sound or see a light, and they don't typically like to be in a noisy or a lit environment. Once they get the headache, they want to stay in a dark, quiet room. They don't like sound. They don't like exposure to light. That's a common description of a headache that is typically called migraine. But then there are various different kinds of headaches, which also can be classified as, sometimes you have neck pain and cervicogenic problems. The layperson typically calls it as cervical spondylosis, which can also cause headaches that could be typified as cervicogenic migraines. And then you have stress headaches, then you have tension headaches. And by and large, they're increasing in number because these headaches are a lifestyle problem. The trigger for migraines include excessive tea, coffee, cheese, chocolate, wine. So most of our Gen Z consumes all of this, and alcohol, um, and inadequate sleep, and excess screen time, and poor hydration. So those are the commonest triggers, or commonest confounders leading to this symptomology of these kind of headaches, and that's why they are on the rise in the youth of today. So if you're able to make a few lifestyle changes, sleep about 7 to 8 hours a day, limit your intake of tea, coffee, cheese, chocolate, wine, and alcohol, reduce your exposure to sunlight. In a way, sunlight is actually great for the body. But supposing if you have these particular headaches, then it might be worthwhile reducing your exposure to sunlight and then seeing what actually triggers the migraine. Every single patient is very different. You can't standardize it, but this is an overview of what one needs to do to prevent these. Obviously, the screen has become an integral and important part of our lives. We can't function without it. Some people suggest to wear filtered glasses to prevent the emission from the blue light of the screen. So those are all the things that one can do because sleep deprivation is also an important trigger for headaches.
Okay, got it. Thank you. The next question I have for you is, can a brain injury heal itself over time, and what are some deficits that can last post-treatment or surgery?
So brain injury, again, let's say, I'm guessing you're referring to if you had a head injury, you've had a fall, you've had an accident.
Yes.
Depends on the degree of the impact to begin with. So the brain is an organ that takes very, very long to heal. So yes, uh, if the damage is not very severe, let's say the patient has had a mild injury, head injury, they tend to heal faster. But let's say if the patient has been in a coma for a long time in the hospital, in the ICU, on a ventilator, then comes out and then recovers from something called as a diffuse axonal injury, where there's a shearing force to the brain, or the brain inside the head is shaken up during the time of the injury. A lot of neurons and axons get severed, and when that happens, healing takes very long. So again, it's individual. It is case based. Some people, depending on the impact and the location of the injury, some people heal faster, some people heal slower. And obviously, when you say does it heal on its own, it does heal eventually, but it has to be aided with specifics such as physiotherapy, speech therapy, occupational therapy, stimulation techniques, exposure to the correct kind of sounds, to exposure to healing frequencies, exposure to everything paramedical that allows the body in general to heal and the brain to recover.
Okay, so in the case of a pathology problem, as you spoke about tumors,
Yes.
would the brain be able to heal itself?
Yes. So once you remove a tumor, most people are okay. There's no real problem that they have. Again, it depends on the location of the tumor. If the tumor is in a very eloquent area of the brain, let's say tumors in the speech area or tumors in the area that controls hand and leg function, then removing it might cause some deficit in that area. But again, once the swelling in the brain subsides and once you've given adequate help post-operatively via different types of therapy, most of these patients sometimes recover. Uh, but if you've damaged something during surgery, let's say a tumor stuck to a facial nerve, where certain tumors in the back of the head are stuck to the facial nerve very, very tightly. And if during excision of the tumor, the nerve gets stretched beyond a point or it gets severed during the operation, then if it's completely damaged, then the chance of it recovering is not possible. But if it's just stretched or pushed or pulled, then they recover. Some recover completely, some recover to varying degrees. Again, it depends on the sensitivity of the nerve and the extent of insult that it has faced, either from an operation or from the pathology itself to begin with.
Okay, got it. The next question is for you. What are some of the most significant challenges you face as a neurosurgeon, and how do you handle them?
So neurosurgery itself is challenging because the kind of cases that we operate are long, are demanding, and are difficult most often. Whenever everything goes well, there's really no challenge to the outside world, but the challenge is for the surgeon when sometimes you need to struggle for long hours in the operation theater. You need to be able to control bleeding. You need to be able to make sure no further damage happens to the patient. So those are intraoperative challenges. Um, Sometimes there are pre-operative challenges where you get extremely difficult patients. They ask innumerable questions. They usually tend to doubt the doctor. They're not completely satisfied with what you tell them. So dealing with those kind of patients is a challenge. But the greatest challenge is in dealing with patients and families when you have a operative complication or when surgery doesn't go the way it does. Patients only feel that doctors, most often patients feel that doctors really don't care about their patients, but that is furthest from the truth. Actually, a doctor feels a tremendous amount of pain and heartache when something doesn't go well with the patient. And it is at that time that you need to spend excess energy, excess time with the patient, with the family, explain to them, keep the communication really strong. It's really painful for a doctor to day in and day out go and see a patient either in the ICU or in the ward that has been harmed because of him. It has a uh, uh, confidence depleting effect on the doctor themselves. But again, thankfully, these are very, very rare situations, but they happen more often than they would happen in other specialties. Let's say somebody who does knee replacements or hip replacements or uh, dermatology for that matter.
Okay, so in addition to that, as you said, neurosurgery, I mean, it is very complex. It involves complex decision making. So, only if you're comfortable, can you share an example of a difficult case you encountered and how you navigated the challenges associated with it?
I mean, I can talk to you for hours and hours about difficult cases that we've encountered. So there was once a guy who, is this a time bound thing? Or can I go on with the story?
We're good on time. Don't worry about
Yeah,
that.
it's okay.
So there was once a guy who uh, came in with a large tumor inside his spinal cord. And the tumor had expanded the spinal cord completely, and the surgery involves cutting open the spinal cord, removing the tumor without damage to the spinal cord, and closing the spinal cord back, uh, and to make sure that his function is preserved. All he had was a little back pain, some difficulty in walking, and some urinary problems. He was in his 30s. And we do this operation with what we call as intraoperative neuromonitoring, where every single muscle of the patient's body is connected to a computer. And if while we are operating, we, let's say, cause a pull or a stretch on any of the muscle which is reducing in power, then the machine will tell us, hey, you're causing damage to the right leg or the left hand, and then we can move away from that area till it gets adequately relaxed, or we decide to stop the operation to not proceed any further to cause any further damage. So when we had taken this patient to the operating theater, and the neurophysiologist told us that they're not getting any signals at all because the spinal cord is so thin and so pushed to its edge, it wasn't transmitting any normal signal. So we were questioning ourselves on whether we should, first of all, go ahead with the surgery. Now, the patient's already under anesthesia. We've already turned the patient on his back. We've already made an incision that's about 1 foot long in the spine. So, but should you go ahead and remove such a tumor? Uh, the risk involved is making the patient completely paralyzed, waist down. Um, and if you go ahead and remove tumor without getting feedback, so the, we discussed it amongst our team, and we said we thought we shouldn't go ahead with surgery because we don't have any feedback. We went and told the family outside that, listen, we're getting the signals that we require to proceed with surgery. What do we do? It's also possible that the spinal cord is so thinned out that you may not get these signals. So they said, listen, we don't know what to do. You decide what's best for him. Then after a lot of contemplation, we went ahead with surgery, and we did a beautiful operation. It took about 8-10 hours. We were able to remove the tumor completely without causing any damage to the spinal cord, and we thought it'll be great. But post-operatively, he woke up completely paralyzed with no movement in his legs. And then I thought it was the worst decision of my life. It was draining. The family was completely disappointed. His wife, who he had recently married 1 year ago, couldn't believe it, because if you don't have leg function, you don't have bladder function, you don't have bowel function, you don't have sexual function. And he was discharged 1 week later in a wheelchair, still completely unable to move his legs. And but I stayed with the family. I you know guided them to do the correct physiotherapy. I didn't know whether he would improve, but to some extent I knew that I hadn't damaged the spinal cord at all. And about 1 month later, he was able to start wiggling his toes a little bit and bending his knees. And then with more physiotherapy, he started walking with the walker. And then but that was a miserable time for me, and I stopped operating on difficult cases for about a couple of weeks. And then 3 months later, he sent me a video on my phone of him having climbed 20 stairs, 20 floors, and was running on his terrace. So I finally was relieved that he was able to come back to what he was before. And I knew that the damage that was caused was only because the spinal cord was so thinned out and probably swollen, and the surgery also adds to the insult a little bit. And once all the swelling and all the edema came down and the spinal cord came back to its normal position, his recovery also followed suit. And then he had a baby, and then he came to me for a follow-up with no tumor in his spinal cord. So uh, that was a very, very rewarding feeling. But those 3 months were quite devastating and challenging. And every year there comes one or two such cases that exhaust you completely. But thankfully, about 98% of them have good outcomes.
Initially, that story sounded very stressful and scary, but I'm so glad it all worked out in the end.
Just listening to it can give you
Yeah,
goosebumps.
it
Going
was
through it,
very scary.
uh, going through it can be. There are so many other stories, but I mean, I'm going to write a book on them.
That's very cool. I would love to read that.
We all would.
Yeah.
Do you read the articles that I write in the Sunday Midday?
I will read them now.
Yes, please.
You can
Okay,
them on
so
the-
moving on to the next question. The last question, actually. What role does technology such as AI and robotics currently play in neuroscience or surgery? And where do you see it going in the next decade?
In 1985, the robot was actually first used in neurosurgery to perform deep-seated biopsies in the brain before any specialty. So it has a great, great future. Nowadays, we are using robotics to lesion certain areas of the brain. We are using robotics for spine surgery to place screws adequately in the spine, especially in big deformities of the spine. So we are using AI to visualize. You can wear the HoloLens and visualize tumors in 3D inside the brain, so you know exactly when you're operating where in the head is the tumor. It's also a great tool for patient education. So the future is limitless and infinite as far as robotics and AI goes. And we've been using these tools very regularly for precision, efficacy, and enhancing patient outcomes. So we are going to be able to try and see how more we can invest in it for more pathologies to make them more and more minimally invasive. Now we can just burn and ablate certain tumors in the brain just with a single probe, where once upon a time you required to remove these deep-seated tumors, and there was a chance of causing some damage while doing so. So these technologies are improving safety, efficacy. You also have to use them with a little bit of caution and judgment, and not let go of your basic foundational training that overrides every decision of the robot that it takes.
Thank you. That was our last question. And now I'll be handing over to Mansi for carrying out the myth and fact round.
Rapid fire. Is that a rapid fire round?
Yeah, it is
No,
kind of it.
yeah, so it is like a myth or fact round. We'll put forward the statements and you just have to let us know if it's a myth or a fact. So the
And give
first,
you an explanation
yeah,
for the same.
sorry, sir.
And give you an explanation for the same.
Yes, doctor, if you can. So the
Okay.
first statement is you can train your brain to improve memory and focus.
Of course, it's a fact. Once upon a time it was believed that neurons don't generate, but now we know that neurogenesis is true, and there are certain techniques that have been described by neuroscientists to improve memory, to boost brain function. But the simple things that one can do is exercise. Improving and increasing blood flow to the brain improves memory. Eating the correct kind of food, eliminating sugar, eliminating saturated fatty acids, and getting adequate amount of sleep and sunlight, spending some time in nature, and having a regular practice of mindfulness. All of these are techniques that help you improve memory and brain function. And if you're Parsi, eating 2 eggs a day.
Doctor, can you suggest a few exercises that can improve the memory and brain function?
Uh, Physical exercise is more important than mental exercise, actually. So
Okay.
something as simple as taking a brisk walk every day,
Okay.
or indulging in some kind of brisk cycling or swimming, or going for a run. Mental exercises include solving crosswords, doing sudokus, learning a new language, or also playing a musical instrument, learning to play a new musical instrument. Besides that, there are a lot of apps that allow you to do certain brain exercises that
Okay.
that could be helpful. But I think physical exercise is more important than mental exercise.
Okay, doctor. Moving on to the next statement. Brain injuries always lead to permanent disability.
That's not true.
Okay.
Like I mentioned to you before, brain injuries, depending on the extent and the severity of the injury, can result in a permanent disability. But oftentimes, if there is a minor injury, the disability is transient and in many cases can even be recovered completely.
Doctor, the next statement is brain cells do not regenerate.
Again, that's not true. They do. Once upon a time, it was believed that they don't, but now we know that we can ourselves uh, induct neurogenesis with things that I told you about, and it's possible to regenerate brain cells.
Okay, doctor. The next statement is memory loss is a natural part of aging.
To some extent, it's true. As we age, we also tend to lose neuronal function. Neurons get pruned, or they get chopped, or they, in some sense, how the skin wrinkles and the hair whitens. Same thing happens to neurons. So as we age, it does affect memory. It does affect physical function as well. And at best, we can do to keep it. That's why nobody gets Alzheimer's when they are young, right? Uh, it's these are degenerative processes of the brain, and degenerative process happen as we age. So this is, in some people it doesn't happen at all, and that's strange, because some people have a sharp and crisp memory even in their 90s. But in some sense, you will, as we age, most people tend to have a little affliction of their memory uh, uh, and other functions that involve sharp functioning of the brain and dexterity of the hands and legs.
The next statement is, once you lose a part of your brain function, it loses its function forever.
That's not true. Again, let's say if there's a tumor pressing on your eye nerve and diminishing your vision, once you remove that, you can restore your vision. If there's a tumor pressing on your hand and leg function area, once you relieve that pressure, you can restore vision. But if you get a stroke, let's say in your vision area of the brain behind in the occipital lobe, and part of your vision is gone, then that may not be possible to recover. So if there's an internal damage to that area, it may not recover. But if the damage or the dysfunction is because of pressure and you relieve that pressure, then there is a chance that that function might recover.
Okay, doctor. That's the end of our round. Thank you, doctor. Thank you for joining us. It was an enlightening couple of answers, and thank
Yeah.
you for interacting
It
with
was
us as well.
very informative and very interesting.
Great.
Yes,
It was a
that's
pleasure for me to be here. Let me know if there's anything else I can do for you. Thank you
yes,
for
doctor.
taking the time out to talk to me. And I
Hmm.
wish you all the best in your pursuit and keep your interest in science alive.
Thank you so
Thank you,
much.
doctor. Thank you so much.
See you.